My colleague and I are very happy to be here today. I'm an epidemiologist at the health department, and she's the director of the Healthy Homes program, and they decided to let me out of my computer and data for a minute to present to you all, so I'm very excited to be here and to talk about a really exciting study that we have. We have an asthma and pest control study in which we fully intend to demonstrate a return on investment for in-home pest control for children with persistent asthma. And I should say, I've actually came to environmental health relatively recently in my career as an epidemiologist, and I was so excited about this study when I got to work on it because it is a vision that I think is very exciting. So with this study, we hope that we are going to provide the basis for a world in which doctors can be sitting down with their parents of children who have persistent asthma and ask them the question, are you dealing with pests in your home? Are you dealing with cockroaches? Are you dealing with mice? And as we all know, in the same neighborhoods that have high prevalence and severity of asthma, they have high poverty and they have lots of pests. So the answer is going to be yes. And then the doctor today asking that question is going to be like, well, sorry about that. But what are they supposed to do? And our idea is that at that point, that doctor could write literally a prescription for safe and effective pest control. And then we at the health department could act as a referral to a pest control company that is capable of providing an integrated pest management intervention that is, again, safe and effective for an individual unit, and that would then be paid for by the insurance provider. And the hope is that our study is going to provide the evidence basically the evidence base that for the insurance industry that their investment will be far outweighed by the savings in healthcare costs from just this simple intervention. So I just want to acknowledge that I know that before I continue on, that it is never just one thing. It's not just cockroaches or just mice for exacerbating asthma. And it's also what we're doing is just a tiny piece in a bigger picture. So as you heard earlier from our Deputy Commissioner Dan Cass, the issues of pest control in New York City are a huge issue. They stretch far beyond what the housing sector can handle. Enforcement is one option and one that we're pursuing with some very innovative pilots at the health department. We can also think about incentives for landlords, but those things alone are not enough to be addressing the problem that we see in our city and I think in other urban environments as well. So we need to look to other places. And similarly, as everybody in this conference knows, you've been talking about in-home asthma interventions. This is often IPM or pest control is one piece of an in-home asthma intervention frequently. And then in addition, that is just one tool in our toolbox to address the disparities that we see in asthma across our city and across our nation. And so at the health department, we're also doing a number of other things. You heard from earlier from the Center of Health Equity about our community health worker program in East Harlem. We also have a lot of work that's going on in school health with school nurses and clinical interventions. So this is just one piece. It's not just one thing. That said, I don't think that I have to convince this audience that, that we definitely know that addressing the home environment is definitely key to improving asthma. I don't want to belabor this. I think everybody has already talked about it, but we do know that the neighborhoods in our city specifically that have the highest rates of asthma and also have the highest severity of asthma are the same neighborhoods that have poorly maintained housing and have pest problems. And this is just a graph that shows that ecologically, so you can see this very clear relationship between asthma ED visits and cockroaches in the home in this graph. And just a quick plug, you've already heard about our environment health and data portal. This came directly from there, so you can get great data and great graphs like this and just plop them into your presentation. So highly recommend that. So we know that it's a problem, and the issue might be at home, but it translates into healthcare costs, right? So that demands, therefore, a healthcare response. So what we are thinking is we have a previously validated integrated pest management intervention. I'll talk a little bit more about that, but in essence, for just as a reminder, this is a prevention-based approach that has multiple strategies to reduce housing conditions that are conducive to pests. And we at the health department a few years ago did a study in public housing that showed that the intervention that we're now taking that protocol and adapting and using in our current study is effective at reducing pests and allergens that are exacerbating asthma. And so this could definitely equal better health outcomes, but to date, as far as we know, there are no studies that have thus far quantified the costs and health outcomes of IPM alone. So pest control is, again, frequently part of larger in-home interventions, but we thought, let's pull out this one piece because this is something that could potentially be implementable in the clinical setting. We can target the most at-risk children in the highest severity communities, and then reduce those allergens in the home, which we know will result in better outcomes for kids. So the study. So we're trying to show a return on investment for IPM, Integrated Pest Management. It's a collaborative project between the Health Department and Montefiore Medical Center, and we have two amazing health insurance partners. You heard from Susan Bean earlier this morning at Health First, and Affinity. We have our colleagues here somewhere out there, wave your hands. And they're working with us and have helped us with recruitment and also with data. We're being funded by the Robin Hood Foundation and the New York State Health Foundation, and then the Health Department is also putting out dollars for this. So we're looking at children who are age 5 to 12 with persistent asthma in homes with pests. And we're going to demonstrate the feasibility of this basic intervention that could, again, be, in essence, prescribed in a clinical setting to evaluate changes in asthma outcomes and asthma-related healthcare system utilization. We're assessing our return on investment, of course, and this last point is last not because it's not the most important. We are working with the pest control industry on a protocol for IPM that is both feasible for them at a price that is reasonable and replicable on a large scale. This is a prospective RCT study design. We have 386 children. That's across 364 families, so we do have siblings in our study, actually more than we even anticipated having. They've been randomly assigned to intervention and control groups, and they are almost all in the Bronx. We have a few in Upper Manhattan. They all have persistent asthma according to the clinical definition, so these are mild, moderate, or severe, no intermittence in there. And they must have at least one ED or hospitalization due to asthma in the past year. And then, of course, they had to have a pest problem in their home. We're doing 3 assessments over a year-long period, baseline 6 months and 12 months. And one of the unique and special things about our study is that we have not only the caregiver surveys for that self-reported data that we're all very familiar with, but we're also using the actual healthcare utilization data from Montefiore medical records and also the health insurance claims data from Health First and Affinity. Our primary outcomes are listed here: asthma-related ED and hospitalizations, and then secondary outcomes of symptom days and days of missed work and school, and numerous other things that we're looking at. And then we do have incentives, of course, for participating in the study. The main one being the free IPM treatment that all of our participants get. And I wanted to mention that. So our intervention group gets the intervention immediately upon entry into the study, and our control group gets the intervention at the end of the study. And the intervention is the heart of our study. So it is a 2-visit assessment and treatment. When this is actually implemented, we would probably take off that initial assessment. That's a little bit for the implementation of the study. But in that initial visit, they identify the pests and conditions conducive to pests, educate the participant caregivers about the treatment that they're going to be getting, and then placement of pest monitoring device or traps, and that's so that we can then assess how bad the pest problem is when we return for the treatment. We leave with the participants containers so that they can empty their cabinets in the kitchen and in the bathroom, so that then when we come back, we can do all of these amazing things. So trapping, removal of mice, removal of cockroaches, and pest evidence, intensive cleaning, which I'm going to show you evidence of in just a moment, including HEPA vacuuming, steam cleaning, and literally just scrubbing with soap and water. And then sealing up cracks and crevices and holes where the pests can get into the unit. And then the targeted application of low toxicity pesticides to reduce cockroach population. So these are pesticides that cannot or will not harm the people living there or the pets that might be there, because they are applied in such a way that they can't get access to them. So I wanted to show these pictures because we really are seeing a big effect just in what we're doing. So in the top left, you can see this is a cabinet in a residence that had a severe cockroach infestation. And what you're looking at on the left side of the top left pictures, that's the same cabinet as the one on the right side of the top left pictures. That's cockroach stuff. So that's dead cockroaches, live cockroaches, droppings, frass, etc. And so after the intervention, not only has that been totally cleaned up, but I don't know if you can see it clearly, but there is a white line along the seam where the two sides of the cabinets meet, and that's where we filled in the crack, which is where all those cockroaches were getting into the cabinet in the first place to eat the food that was there, which was why they were so excited to be living in that apartment. Down below, on the left-hand side is actually a mouse nest. I just want to tell you that I'm sparing you all the pictures of dead mice and dead cockroaches that I had decided you didn't want to look at those. But this is a mouse nest, and the droppings and urine stains, those are the allergens that the children or adults as well can be reacting to. And then again, that's been cleaned up, and you can probably see some of the patching that's been done along the edge of the wall. And then the top one, again, on the far right, is, again, cockroaches, and I'm showing this one because it's kind of interesting. This one actually didn't have any entry points, but showed that there was such a huge infestation problem that the cockroaches figured out a way to, in essence, get in the front door of this cabinet because there was so much good food for them to be eating there. So we are now at baseline. We're doing our baseline analysis. We found that we have a good steady population to assess the independent effects of IPM on asthma symptoms and healthcare utilization. We're, in essence, jumping up and down with joy. Our randomization worked. The majority of our kids are on Medicaid and living in households with incomes that are below the poverty level. And what we found is that they are well managed in that they are on those controller meds. They do have their rescue inhalers. But they are poorly controlled. So they're exactly what we were sort of expecting to see and are what we want to be trying to make an impact in. And they all have significant pest infestations in their homes. So stay tuned. We expect to have our results by the end of the summer next year, and we're very happy to answer any questions. Thanks.